Thank you very much. I'm afraid my French is really so terrible. I have to really give this presentation in English or you would have no idea what I was talking about. Do I just click to? Okay. So it's a huge pleasure and I'm very grateful to have been invited to come to this meeting. And I understand that this is your inaugural paediatric oncology session in this meeting, and that is very special to me because I've been working in paediatric oncology for more decades than I perhaps would like to admit. And it has only really been recently that we feel that the word of paediatric oncology is really being heard now. We've often been at meetings asking for sessions, asking for visibility, and it really hasn't been considered of major interest to our adult oncology colleagues, whereas I think there is a huge amount of work that we do that is relevant to adult oncology and vice versa. So I think it's fantastic to have a meeting such as this where a session is embedded within it and we can share a little bit about paediatric oncology. So I just want to give you some of the bare facts. Many of you in the room maybe know this already, but I think it's worth repeating. We cannot forget that childhood cancer remains the commonest cause of death for children in the Western world from disease. And quite often we hear, and I have heard, particularly in policy meetings at funders, that childhood cancer is sorted. We know how to cure childhood cancer, it's 80% survival. Well, that's true for some cancers, but overall it's still, from disease, the commonest cause of death, so our job isn't done. And we have, in Europe alone, 35,000 children every year are diagnosed with cancer, and 6,000 of those die. But really importantly, because of our high survival rates for some cancers, we have nearly 500,000 children who are now adult survivors of cancer. And that's fantastic, and some of them are living really wonderful lives with their own families. But over 2/3 of them suffer from the problems of the disease they were diagnosed with and or the treatment that we gave them. And when I say suffer, I mean problems like long-term cardiac problems, infertility, which is something that young people didn't even cross their mind when their parents were trying to grapple with the fact they just want treatment to cure their child, and then they have to deal with the tragedy of infertility in their later lives. They have difficulties with employment, and they have major psychosocial problems. So it's a big societal problem as well as a medical problem. Inequalities. So I think many people think, well, you know, there's 90% of children with cancer who die are from the third world, and this is true. If you look globally, that is true. However, just in Europe, you know, we're a very wealthy part of the world. There's a 20% difference in survival rates when you go from west to east in Europe. And that's in countries that should have good standards of care, but that isn't the case. And these are things that as a society we are trying to address. And just to explain the society, which I have the honour to currently be the president, we're a society, a member society. Our members are paediatric oncologists, haematologists, radiation oncologists with an interest in paediatrics, surgeons and radiologists. All the medical healthcare professionals can be members. And at the moment we have over 2,000 members across 30 different countries. And we have representation from all the national societies of paediatric oncology around Europe. And within themselves, they're organised into clinical study groups, some of which are disease-specific. So, for example, Siop is a disease-specific clinical trial group for neuroblastoma, a type of childhood cancer. Then we have cross-cutting trial groups, one of which is ITCC, Innovative Therapeutics for Children with Cancer. And that's a group that looks specifically as how do we bring innovative new treatments, early phase trials across all types of diseases to young children. So society is quite all-encompassing. Our three pillars are research, advocacy and policy, and training. Training is in some ways the newer pillar. We've never really invested in a proper training program for paediatric oncologists until recently. We've worked very much alongside other organisations like the European School of Oncology, but going forward we're developing a new training program that is accessible to all European paediatric oncologists. The research and policy and advocacy we can't do without our partners. Oh, seem to be stuck. what would come up here now, is to show you that we collaborate with the European Paediatric Advocacy Group called CCI Europe, and also PanCare, which is a survivors group. And together, the three of us have a memorandum of understanding to address the problems together. I don't seem to be able to advance the slides from here. There we go. Good. So as a society, we, about 5 years ago, put together a strategic plan which defined our 7 medical and scientific objectives to address all the different aspects of childhood cancer. And this extends from trying to develop innovative therapies for children with cancer. The number of new drugs that have been licensed in childhood cancer over the last decade or so is only 9 new agents. If you compare that to the adult world, where there'll be a 10-fold difference at least. And this is because industry has not really focused on childhood cancer very much until recently, and that tide is changing, but it's changing very slowly. And we need to learn much more about the biology of childhood cancers so that we can apply the precision medicine programs that are being rapidly developed with the effectively avalanche of new drugs that are coming out of industry. The bit I want to focus on is equal access and inequality, and I'll come back to that in my next slides. But we also need to address the discrepancies there are in access to new treatments for teenagers and the specific problems that adolescents have with being diagnosed with cancer. And I've mentioned the survivorship, and I'm going to show you a slide about some of the work we're doing to support survivors of cancer. So, in terms of equal access, in the last couple of years, we've been working very closely with a program called JARC, which is the Joint Action for Rare Cancers, as well as the European Reference Network for Paediatric Cancer called PEDCAN. Our PEDCAN, our European Reference Network, is a far-ranging network with full and affiliated members right across the EU, which is now a network of specialist centres around Europe that have expertise in childhood cancer, but also networked other centres that need that additional expertise that they can get from the bigger centres. So we've brought them all together under our European Reference Network. And although this is the number at the moment, you'll note at the bottom there's been a new call last year, and we hope to have new members in the next year. And the whole aim of our reference network is to improve the equal access to the best cancer care for all children. And I'm talking here about standard treatments, not necessarily innovation. And the way that our ERN aims to work, and it's only starting to be implemented now, is that rather than moving patients from countries to a specialist centre in another country, but to move the expertise. And we're doing that by virtual expert tumour boards. So clinicians in any country can put forward a difficult case, a challenging case, to experts in a virtual tumour board and get the advice and guidance from people who know what is happening in that field. That may well identify that they can have that treatment in their own country, or it may identify that there's a specialist part of treatment that is only available in another country, and then that will be, in the second point there, facilitating cross-border healthcare. Cross-border healthcare, as you know, is a right within the EU. Where that stops is in terms of clinical trials and innovative treatment, and we're working on our policy and advocacy work to try and get that changed so that the cross-border healthcare can apply for clinical trials as well as for standard of care. And it may surprise you to know that as of today, we do not have a suite of standard treatment protocols that we could give to every country to say that for every disease, this is how a childhood cancer should be treated. What we have are a lot of clinical trials that have standard arms, but those trials aren't necessarily open in particularly the Eastern European countries. So it is correct that we now develop the standard treatment best recommendations so any child in Europe knows what the right standard of treatment should be. And if that best standard isn't available in their country or in their centre, they then have something endorsed by Siop Europe, something physical to say this is the treatment I should be having. And we're hoping this will stop this idea of almost what we would call in England a postcode lottery of healthcare, that people will know what the healthcare they should be getting in their own country, in their own centre, and get access to it. Other work that we've done with a number of partners, and I've tried to acknowledge many of the partners down the left-hand side, radiotherapy treatment. Radiotherapy is not standardized across all countries in Europe. We did a survey of 250 radiotherapy centres, paediatric radiotherapy centres in Europe, in 34 different countries. On the basis of that survey, have published some recommendations for best radiotherapy standards for children with cancer. I'm going to come back to a project we've done on access to medicines. I haven't really put very much in about innovation, and I could talk for an entire hour on what we do about early phase trials and attracting new drugs into children with cancer, and I'd be happy to talk to anybody about that afterwards. But we've got two programs, one the clinical trial group I mentioned, ITCC, and another more advocacy program called Accelerate, which is a global initiative where we've brought industry, regulators, parents and clinicians together to really get at what are the policy changes that are needed to drive innovation in childhood cancer. Even within childhood cancer, which is rare in itself, there are rarer cancers within it. And we've worked very, very closely with an expert group, it's called Expert for rare cancers in childhood, to have some consensus statements about the treatment for those ultra-rare cancers. So I mentioned the access to treatment. We did a piece of work to look at the availability of what we've called essential medicines. Essential medicines is defined by the WHO, and we did an additional piece of work to see if which particular drugs were essential to paediatric oncology. And this work was led by Gilles Vassal, working closely with the young oncologists in Siop Europe. And he identified, or the group identified, 68 chemotherapy drugs that are the backbone of all childhood cancer treatment. And they surveyed 34 different countries across Europe and asked the question, were these drugs available routinely all the time for your children with cancer? And only 30 of 68 of those drugs were available all the time in paediatric oncology. I promise I didn't touch anything. Nothing. Yeah, nothing's happening. I'll carry on talking so we don't run out of time. The slides will catch me up. Of those drugs, only 30 of 68, that's 44%, were available in the preceding 2 years in more than 90% of the countries surveyed. So over 60% were not available to a child who needed them. Are these rare drugs? No, we're talking about drugs like vincristine, asparaginase, doxorubicin, routine drugs that are often not available to children with cancer. So that's a huge problem. So our complete work, this work is ongoing, and we absolutely need to find a way to address those shortages, and that has to be done at a policy and parliamentary level. We also, at the other end, there's new drugs coming online like CAR T cells, which are outrageously expensive and not available easily across all of Europe. And we need to work with the health technology assessments about how we price these sorts of drugs to make them accessible. 27% of drugs, oral drugs, are never available in a formulation that children can take. And, you know, many of you are parents in the room, you know what it's like to get a drug or a tablet down a child who doesn't want to take it. And that is not being considered for nearly a third of all childhood drugs. And the other, which we've not addressed yet, but is equally important, is that although we've looked at chemotherapy drugs, there are really substantial inequalities in access to pain control and pain management, particularly not just in palliation, but just in routine care across Europe. And can you imagine having your child diagnosed with cancer and not having access to the appropriate painkillers to manage them? So all these recommendations are in a book called the JARC book, and there are 10 recommendations for adult cancers, and within every chapter there's a dedicated section on childhood cancer, and we're using this book and the recommendations within this to lobby at the parliamentary level to get this included in what is expected to be a European beating cancer plan, that we have paediatric oncology within it. A couple of words on survivors. I've told you that 500,000 survivors exist from childhood cancer in Europe today. 2/3 have long-term side effects, and we need to make sure that once children transition from acute care, their long-term care continues with the multi-professional, multidisciplinary teams that they need, bringing in the experts that are relevant at that time, for example, the fertility experts, the cardiology experts, the endocrine experts, as part of that team, so that the well-being and quality of life can be there throughout their life. And one piece of work we've done for this is something called the Survivor's Passport, or Survivorship Passport. And this work was led by Cinica, a spin-out company, IT company within in Padova, working closely with PanCare and CCI Europe and the International Guidelines for Harmonisation Group to generate documents that are the summary of the patient's care, the predicted potential long-term side effects that those children might experience, the sorts of surveys, the investigations that need to be done long-term, and then what to do about them. And these, at the moment, are available as a paper document, but also electronically. And our plan, when we have a sufficient investment, is to roll this out in every country that needs it, so that a patient who's finished cancer treatment will get their survivorship passport, either in paper or online, and be able to go to their teams and say, this is the care that I need. Part of doing it online is it means that we also get a database together to be able to do research into survivorship. And the important thing, it's written in a language that patients understand. It's not for the doctors, it's for the patients. We need more investment in childhood cancer. And earlier this year, Richard Sullivan from King's College London published a paper about the discrepancies in investment in childhood cancer research. And he demonstrated that there is a 10-fold difference in the funding level that the US invests in childhood cancer compared to Europe. And that is not a difference in the population size. Our populations are quite similar. Certainly not a difference in our financial capacity. It's just an interest in where the investment goes. Now, the EU certainly has invested in childhood cancer, and we've benefited from it within the Siop Europe community and have delivered a number of projects that have been very productive, but it is only really a splash in the ocean to the sort of investment we need. And so we've published recently in Lancet Oncology a call to the European Commission to say that we would like a cohesive funding plan for childhood cancer, and we called it aspirational reality. I'd like to believe it's a reality. And what we put together, all missions have to have a measurable outcome. So our measurable outcome will be to halve childhood deaths and halve the burden of childhood cancer by 2030. And I think this is achievable. We need to bring together groups that don't normally work in paediatric oncology. We need to bring people in the digital sector, discovery science, human and social sciences all together to address our challenges. And the programme will be very interlinked with research from basic biology through to social science and quality of care. And a particular area that we do need to start focusing on is the causes of childhood cancer. So this is what we could do at a research level, but we need our politicians to be on board. And so we've written a manifesto, which we published just before the European elections, stating what we want the European parliamentary MEPs to do in these 6 areas to help us develop more innovative treatments, to put the resources there for us to support research, to make the reference networks sustainable, to support our long-term care models for survivorship, and to develop the interoperable e-platforms that we need to be able to share data and ultimately empower our patients so that they can go on to live good lives. This was supported by over 33 MEPs before the election and more than 1,000 individuals. So we feel the message has gone out there. And we're going back to the Parliament next month, or this month, February's next month, for a day, the International Childhood Cancer Awareness Day, and the focus of that day will be on artificial intelligence and digital healthcare. So the challenges still remain. We're still working, just giving you some examples of what we're doing to address the inequalities in childhood cancer care and survivorship. But at the moment, when a parent says to me, why did my child get cancer? For the most part, I have to say I don't know. And that's not good enough, and we need to invest to really answer that question in the future. So I just want to finish by saying thank you to my board and to the office that support me in Brussels, and to invite you all to attend our second international meeting in Valencia in May. Thank you.
Thank you very much, Pamela. In English?
Yes, in English.
Have you any idea of how connection can be performed between different countries at the level of research team or hospital or cancer center? Have you an idea of how
So,
can be proactive on this?
Yeah, so we are really very proactive. All our clinical trial groups are multi-country, multi-centre and multidisciplinary. And just to give you an example, in my own unit, I'm the director of a trials unit in the UK, and we run European trials. We have 14 clinical trials in 37 countries across Europe, and equally we participate in countries that are trials run by France. And so it is possible. It takes funding. This is the biggest challenge, particularly because the funding often comes in at different times from different countries, unless you're lucky enough to get EU funding. And we do have to, one of our biggest challenges is material transfer. So if we're doing biology research, getting the agreements in place to transfer material across border. And GDPR has undoubtedly made sharing data more challenging. But getting the expertise together, that once you've sorted out the pathway for the tissue flow and for the data flow, the will is there to do it. And we've shown that actually we've got some very good international programs.
Question? Olivier?
I was very impressed by this 10 times difference between funding in the US and Europe. And this is just a question, is it all included, meaning public money, private money from farmers, charities, advocacy, all included?
Yes, absolutely. So the research was done gathering as much public data as available, both in what was published, approaching funders directly, and then the unit that did it does a lot of what they call the grey internet, where they go really deep into different areas of pulling out resources, and they redid the analysis to include what you might call the softer funding, the philanthropic funding, and it was the same regardless, where all the small percentage difference, but overall it still came out as a tenfold difference. So, and what was interesting, it's not just that the US funds more, but that money is spent in the US. So it goes to US institutions. It's not that the NCI is giving money to institutions in France or in Germany. The money stays there as well. And there's a piece of work that we did recently that's going to be published this month that showed about research papers coming out of different parts of the world. And the collaborativeness of Europe was very evident. Multiple countries, multiple papers answering the question about collaboration. That in the US, that doesn't tend to be the case. So the research is very US-centric. I'm not saying there's anything wrong with their research, but the discrepancy, I think Europe's got a lot to do to really focus on childhood cancer.
The last question, Nicolas.
Do you have any idea how that Brexit will affect the collaboration between different countries?
Do you know? Yeah, it's a very good question, and I felt I ought to wear a black armband for tonight, really. So there will be an impact. So I think the will for collaboration will still be there. I think at our level, at the researcher level, Brexit is not an issue for us. We still want to collaborate. Where the challenge is going to be is in terms of making sure that well, it's what the UK's responsibility is going to have to be, and trust me, I'm lobbying our government to stay aligned so that, for example, we maintain the same privacy laws so that data can come into the UK. We maintain an alignment with the forthcoming clinical trial regulation so that we can be able to do trials. For all the different types of collaborations, there will be a way to collaborate. It is just going to take more effort to do it, and it's going to be more expensive.
So how it's going to be like if we have a European trial and then the UK is the main sponsor? They stop right away? Or
No. So I have spent the last, because this is basically my day job, is what I do, is sponsoring clinical trials as our organisation, and we've been preparing for this for the last 18 months. So I can tell you what will happen. We've already got this in place. The two pieces of law that we had to address were three pieces of law. One was the legal representative. So we've appointed a legal representative in Dublin, as in an EU member state, so our trials will be able to continue. We put specific contracts into place with all our partners for data protection so that data can still transfer. And we've looked at the drug supply issue, and if we had a new agent that was being supplied to an EU member state, we've moved the supply into an EU member state. That was the bit that was the most expensive. So it will happen, it's just cost quite a lot of money to do. The other way round, so if sponsoring and UK participating will be relatively straightforward because the UK has taken a very permissive attitude, so they're not expecting, for example, a French sponsor to have a legal representative in the UK. It will carry on as it was before. So that way will be easier.
Okay, thank you. We have to move on to the next speaker. Thank you very much. Bye.